Yeah, so my name is Austin Fox. I'm a glaucoma specialist and a cataract specialist here at Gavin Herbert Eye Institute, and it's a real pleasure to be here with you. I'm thrilled to talk about glaucoma, a subject I'm really passionate about because it's a treatable disease and it's one of the leading causes of blindness. Um, yeah, so throughout the chat, y'all feel free to put questions in the Q&A. I'll be checking it, and I may stop and at a couple of intervals and answer these questions just throughout. So as an overview here, the goal of this talk is to talk about glaucoma and glaucoma management. First, we'll review eye anatomy, and then we'll just talk about some basics, background of glaucoma, and then review glaucoma management, old and new treatments. So the optic nerve comes into the back of the eye, and it's sort of this information highway between the eyeball and the brain. And the eye focuses light onto a tissue in the back of the eye. This is called the retina. And the retina is composed of a number of cells, and one of these cells types is the optic nerve. And so the light signal is processed by the retina, and the optic nerve cells go and travel in this cord, and it's sent to the brain where we experience vision. So the optic nerve is a bundle of over 1 million nerve fibers responsible for transmitting the nerve signals to the brain. And you can see here the optic disc is the front surface of the optic nerve. And so this picture on the right, it's the image that an ophthalmologist might see when we look into the back of the eye. It's the front surface of the optic nerve, which we can look at to detect glaucoma. And so we're able to tell whether the optic nerve is healthy or if it's damaged. And you can think of this as kind of like a donut right here. And if there's a thick rim of dough, then the nerve is healthy, as seen here on the left. And then if there is a thin rim or a thin amount of nerve tissue, as you can see here on the right, then this is glaucoma. So by getting a basic eye exam, including vision, intraocular pressure, dilated eye examinations, where we look at the optic nerve and we're able to screen and evaluate for glaucoma, then we can detect and monitor. And I think that's really my first takeaway point. Screening is the most important tool that we have to identify and prevent vision loss from glaucoma. There is no cure yet for glaucoma, but if it's caught early, then we can preserve vision and prevent vision loss. And so if you have risk factors and it's warranted based on the screening, then we may get a measurement of the optic nerve to identify and to really quantify any thinning of the optic nerve, which you can see here in the color red. This is more of a structural test to evaluate the optic nerve. For more of a functional test, we use a visual field to evaluate the central vision and the peripheral vision as well, because glaucoma manifests initially as peripheral vision loss, which we can detect with this visual field test. And so just to kind of put this together here, a healthy visual field is seen here on the left. And so I overlaid a few of these blue cartoon cell fibers of the optic nerve cells to depict the optic nerve cells as they combine and they form the optic nerve. And over the years, you may lose these cells progressing to the right. And with the loss of these optic nerve cells, there's loss of visual field, as you can see here on the far right. And so this really manifests as, a visual field that, you may have heard of tunnel vision. And so on the left, you can see that this is a full picture of these two children. And then as we have progression of glaucoma, you may get peripheral vision loss or tunnel vision. And so that's one issue with glaucoma. You don't have any signs or symptoms in the early or moderate stages. So classically, it is called a theft in the night because it may only be detected with eye examinations until you're out of the early stages when you actually notice vision loss. But fortunately, we're able to slow down or halt this progression with treatment. So how do we treat glaucoma? Well, the treatment is to lower the intraocular pressure. Now, this isn't blood pressure. I often get that question. How is blood pressure affected the intraocular pressure? Is it the same thing? Well, it's not. It's actually the eye pressure, the pressure inside the eye. And so intraocular pressure is the only modifiable risk factor to slow down progression of glaucoma. And so this is really a plumbing issue. You know, there's a faucet, which is constantly making fluid in the eye, and there's a drain, which is constantly draining fluid. And so this fluid is called the aqueous. And so you can see this term right here, the normal aqueous flow. And so this fluid comes in, and you can see this red arrow kind of depicts the normal aqueous flow, and then it goes into this drain right there in the front part of the eye. And so if the pressure rises, if the drain does not work, and high pressure causes damage to the optic nerve. I'm going to take this question right here, this chat. Let's see. That's a good question. So essentially the question is we have a very strong history of glaucoma in our family. And, you know, family history is a big risk factor for glaucoma. It's one of the leading causes of one of the leading risk factors. And so, you know, you have a higher chance of developing glaucoma if you do have a family history, but it's almost like a blessing to know that you have a family history because you can be screened and you can be monitored, and glaucoma is very treatable, as I'm talking about right here. So yeah, how do we treat glaucoma? Well, you know, the management of glaucoma is to lower the eye pressure, and we lower the eye pressure by using eye drops. And so really drops are the backbone of glaucoma management. And there's about 15 or so drops in 6 different classes of medications. And we're going to go over some of those right here. Oh, so this looks complicated, right? But, you know, we're going to simplify this for us. And, you know, every patient, every person's situation may be a little bit different, and some drops may not work as well or may not be as well tolerated by every person. You know, there's multiple names for every drop, and, you know, it can be really confusing, but every bottle cap has a color and I think that's the easiest way to identify glaucoma drops is by cap color. And so here I show each class of medication, and, you know, under each class, you can see that there's a different color, and these are meant to correspond to the cap color for that class. And so you'll see these different colors throughout the presentation. And so up at the top, you can see that the drops either increase the outflow of fluid from the eye, or they decrease the inflow of the aqueous fluid to reduce the intraocular pressure, to achieve that lower intraocular pressure. And so from here, we'll review the different classes. So this is a class called prostaglandin analogues. These are really our workhorse of glaucoma drops, glaucoma management, and they increase the aqueous outflow. They're the most powerful drop we have, and they lower the pressure by dosing once at night. So they're pretty easy to take just once at night. There are 4 different prostaglandin analogues currently available for clinical use, and you may be familiar with some of these. There's latanoprost. Zelprost is a preservative-free alternative latanoprost, and then Bimatoprost, travoprost, and then tafluprost. Those last 2 being preservative, using an alternative preservative, or the tafluprost is truly preservative-free. Generally, I would start with latanoprost because it is less expensive. It's inexpensive, and it's a very good drop. But as a whole class, these are highly effective. They're well tolerated. And so I guess why wouldn't we start this drop, or why wouldn't somebody tolerate this drop? Well, you know, there's a couple of things. There can be irreversible change in the iris. And so you can see right here, there's an irreversible color change. This is observed in about 1/3 of patients at 5 years. And, you know, this is not really an issue for light colored eyes. It's mainly for dark colored eyes. But, you know, really functionally, this doesn't really have any consequence. And then a few other things, the skin around the eye can change color. There can be a darkening of the skin around the eye. This is reversible. And so if that happened, we would stop the drop. You know, eyelash growth is a side effect, which a lot of people actually really like, but it also doesn't have a functional consequence. And then there can be red eye, which occurs in about 10% of patients, but this drop is dosed at night, and so generally it's you don't see that red eye because you're asleep at night. And then some patients, you can get this orbital fat atrophy, which you can see here. There's the orbit, the bones that surround the eyeball can have some fat that cushion around the eyeball. And you can see that there's a deep area right here with this shadowing around the bony area. And that's because there's the atrophy of that fat. And so, a lot of times people are concerned about the cosmetic appearance of, their orbit on this drop. Again, it's pretty, it's less common. And then lastly, prostaglandin analogues are relatively contraindicated in patients with history of herpes infection because it can cause worsening of this infection. Okay, so the title of this talk is kind of alludes to like newer medications, and so Vyzulta is one of those newer medications. It's related to the prostaglandin analogs, and it also has this nitric oxide component to it. So it kind of has a multi-mechanism action to lower the pressure. And one study showed that you did get a 1.2 point lower pressure lowering effect over latanoprost. But it can be a little bit more expensive. So it's a newer drop. Sometimes it's not fully covered by insurance. Timolol is another staple that works by decreasing aqueous production. It's dosed once daily in the morning. And there are 4 beta blockers, which are currently available for clinical use. And so timolol, levobunolol, cartadolol, betaxolol, those are the 4. And though patients can develop allergy to these drops, generally they're pretty well tolerated locally, but what can limit its use are the systemic side effects, which are seen here. Primarily, you can see some wheezing or bronchospasm in patients with COPD or asthma, or you can see that patients may have a little bit lower of a heart rate on these beta blockers, along with these other side effects shown here. All right, I'm going to take these questions in the chat here. Oh, good question. I can touch on pseudoexfoliative glaucoma for sure. I might take that question after the treatment option, the treatment section of the talk. Okay, the next question is, I have both macular degeneration and glaucoma. And it sounds like we're using Compergen rice daily because the drops don't work. I don't think that Compergen rice, I don't know the ins and outs of this medication. It does not sound like it's FDA approved, but I'm not super familiar with it. I'm not exactly sure how it would cause a decline in your close-up vision. Oh, okay. Maybe we can get that question and we can we will answer it in a bit. Okay, so the next class of drops is brimonidine, so or alpha-agonist. Brimonidine is what we think about when we talk about alpha-agonist, or you may hear alpha-gan. And so that lowers the pressure about 20 to 30% through decreasing the production of the fluid, the aqueous. It's dosed 2 to 3 times daily, and generally it's a very good drop. You may hear about it when it's combined with Comagan. The other drop, aproclonidine, which you see here, we generally don't use this one long term just because there is a side effect of ocular irritation with it. Brimonidine can also cause irritation. and you can see allergy in patients on brimonidine about 30% of the time. This is a picture of conjunctivitis in a patient that's using brimonidine. And then, the other thing is we don't use brimonidine in babies or young children, and that's because it's associated with, decreased breathing rates or, somnolence or I guess, depression of the central nervous system. On the flip side, ironically, brimonidine is the drop that is considered the safest for early pregnancy. So actually, we do use this drop oftentimes in pregnancy. Next, we have carbonic anhydrase inhibitors. And so these drops, primarily dorzolamide and brinzolamide, they lower the pressure about 15% by decreasing the aqueous or the fluid production. They're dosed twice daily. And the thing with these drops is they may sting a little bit, but another issue with this drop is that you can have a little bit of corneal irritation or irritation of the cornea, which is kind of the windshield of the eye. And so we are cautious using these drops in patients who are at higher risk for corneal decompensation. So also these drops are sulfonamide derivatives, but there's really they're well tolerated in patients with sulfa allergies, but it's just something to be mindful about. Okay, here's another relatively newer drop. It's you may have heard of the drop Ropressa or Notarsadil. It's in the class called Rho kinase inhibitors. It works by multiple mechanisms, so it may work well for patients who have glaucoma that and that already have a low pressure or something that we call normal tension glaucoma. So this is a very effective medication, and it is about as effective as latanoprost, and it's non-inferior to timolol. Side effects, really the main side effect that's been reported is red eye, and patients do get red eye at a high rate with this drop. Otherwise it's generally well tolerated. And then, so that's the last individual medication I'm going to talk about. But there are fixed dose or combination drops which are available and commonly used, and we really prefer these over separate components, primarily because it improves or facilitates adherence. It reduces your exposure to the preservatives, and it possibly reduces the cost of the drops. We also have a number of preservative-free or BAK-free or benzalkonium chloride-free drops. So that's a preservative that we often use in glaucoma drops, which can be irritating. And so these are for patients who cannot tolerate these preservatives. Okay, so those are all the drops right there. Let me just hop on the chat real quick just to see if there's any, what questions we have. Okay, okay, yeah, that's a good question. Okay, so the question is the last question that came in, and I'll work my way up to the the top of the list, but please discuss the eye pressure range. Okay, so what's a normal eye pressure range? And at what number would treatment be advised? Okay, I actually have a slide right here, and it kind of talks about like what's a normal eye pressure. It varies widely. I actually didn't include this in my initial talk, but I did have this slide. The average is about 18 in the normal population. It ranges from about 7 to 22. And then, the glaucoma specialists like to use this target IOP. And, this target IOP is individualized. It's different for each patient. And for glaucoma patients, we're going to establish this target IOP based on the pressure where we see progression. So we're going to want to stay below that target IOP. There is a study that looks at the question of when should we treat patients with high pressure. It's called the Ocular Hypertension Treatment Study. And that study showed that it is useful to treat patients with ocular hypertension or high pressure. And so generally, we're going to treat patients with a higher pressure, above like 22, 23, 24. And we do know that there's less progression of glaucoma when lowering the pressure. Okay, let's see. Okay, so we're going to go back to the question about I believe it's Alpha-Gan and Combigan. So Combigan is one of those fixed dose, the combination drops. And so it is a little bit more effective than just the Alpha-Gan. And so you can see right here, the Combigan is right here in the second photo here. And so that's, really, it's hard to go back and prevent glaucoma or reverse glaucoma. But as long as we move forward and we control the pressure, with drops or surgery, laser, then we may be able to, prevent further vision change. And I'm glad they were able to control the pressure with a Combigan. I might move forward, and then I'll take a few more questions after we, cover a little bit more ground. I might answer a few of these questions. That's my reasoning here. Okay, so we talked about target pressure. So, after we're determining that a patient needs to be treated and we set a target pressure, we're going to put all of those drops together and kind of review this algorithm of how are we actually prescribing these drops? Which drops are we combining? But this is really the basic way to algorithm to, start and progress through treatment. So we're going to start with a single agent. And let me see if I can get that here. So, unless the IOP, the pressure is really high, for me, that single agent is going to be latanoprost. It's our most effective medication. And if there's a decent, but, maybe we're not hitting that target pressure, then we're going to add a second agent. And that drop for me is going to be timolol. And that's dosed once in the morning. And so right here, we're on a drop at night and a drop in the morning. And so in this process, I have over here on the right, there's different contraindications, or they're based on just systemic diseases or other eye diseases. And, I'm usually skipping that drop if any of these apply. And so next, after the timolol, I'm going to actually move on to the combination drop, Cosopt, and that's adding dorzolamide to timolol. So that blue top is a combination of that yellow top and then dorzolamide, which is many of you may know that it's a orange top. Okay, and so after that, if we need more pressure lowering effect, I'm going to add a purple top in the brimonidine. And so up to this point, we're using generic medications. Brand name medications may be helpful if the medication is not tolerated, but rarely would I change to a brand name within a class if it's not effective. And so if there is minimal effect, I'm usually going to move on from the class and try something new. And so once we get down here to the bottom, I'm asking myself, we're on 3 different bottles of medications. And so I'm asking myself, can the patient tolerate these medications, and can they afford this medication load? We do know that with each additional drop, the combined effectiveness of the drops and the likelihood of non-adherence goes up. So, I think that, the next step, if, we wanted to try, one more drop, I'm going to be adding that Ropressa or that Notarsadil. And so while drops may be, they will always be a part of glaucoma management, we are moving in the direction of reducing drop dependence. And so, one way to do that is this drug delivery through an implant into the eye. So this is a drop, or it's actually a prostaglandin, which is an implant. And, we actually just deliver this micro implant into the anterior portion of the eye. And so this is really exciting because it's the first and only sustained release medication, which is designed to release this prostaglandin, Bimatoprost, over a 90-day period. And so the next point, the FDA approved this for a one-time use, So this is, you may say, oh, well, isn't glaucoma a lifelong condition? Like it's only approved for a one-time use. So is it really that helpful? Well, I think it's more that this is a major breakthrough and moving away from drops. And that you're right. This is it limits the relevance being a one-time use, but glaucoma is a lifelong disease, and I think we'll continue to see this area evolve and see more implants so that we are treating more effectively, making drops more medications more tolerable. And so there really is a paradigm shift. And like Durista, there are multiple other intracameral implants, as well as punctal plugs, contact lenses, and then medications you inject around the eye. And many of these are currently in trials. And so this is a really, really exciting thing as a glaucoma specialist and for patients, which will allow us to better treat patients and move forward in the direction of eliminating these adherence barriers, which we see with drops. So one more newer device, which I wanted to just touch on, which helps us, tolerate drops a little bit better, is the nano dropper. And this is an adapter for eye bottles that, decrease the drop volume by about 60% compared to like a currently oversized eye drop. So you can see right here, this is a much smaller drop compared to a typical drop volume coming out of this bottle. And this is a nice, device because it extends the medication, it decreases the side effects, so there's less preservative that's irritating your eye. It reduces the cost of your medications, and then it's actually easier to squeeze the bottle. I have I don't know if y'all can see this right here, but I actually have one right here. And so this is a normal bottle right here. Let me see if I can get it to show up here. It's kind of blurred. Okay, so this is a normal bottle here. And this comes in a little blue adapter, which you can see here. I don't know if it's too far away. Dana, can y'all see that?
Not very well.
Not very well. Okay, so there's a blue adapter, and actually I'm just going to show you right here. I'm going to go ahead and put it on just so that you can maybe see it a little bit better. And then, once you put that adapter on, this is a very small volume that would come out of this bottle. But, the eye can only hold about, 10 microliters of volume. And so I'm just going to screw this on right here. And, that's it. You just keep it on like this. And this reduces the volume by about, 60%. And so usually when I'm going to put this drop in, I'm going to look in the mirror and I'm just going to pull down right here and just put it in this lower pocket right on the inside of my lid. And that's generally, I think that's the easiest way to put in, medications. And, so I'm looking in the mirror and I'm holding down one lid, the lower lid, and then I'm just dropping a tiny drop into this lower, we call it the fornix, but this little fold right here, just on the inside of the lid. And, generally we don't see a lot of side effects around the eye when we do that because we're not getting the drop on the skin, which can be irritating actually. So if we do avoid putting the drop on the skin, that's great. If you do put the drop on the skin, just try to gently dab it off, but don't scrub it off because that can be irritating as well. Okay, so what's another way that we can get away from eye drops? Well, another great alternative is to drops is maybe laser. And so this is actually something that's caught on more and more in the last few years. It's called selective laser trabeculoplasty, or SLT. It's a form of a laser procedure that's used to lower the intraocular pressure, by, essentially using an in-office procedure, which is painless, to, essentially clean out the filter in front of the drain. And so you may know, or you may have heard of the term trabecular meshwork. Well, it's sort of like a filter for the drain. And we essentially use this laser to clean out the drain. And I'll just show this right here. So this is kind of the view that we see in the office here. We see this pigmented tissue, which is the trabecular meshwork, and we deliver energy or laser to this pigment 360 degrees around the eye. And you can see that here. And we're aiming this laser with a lens, which you can see, which we place gently on the eye. And so this takes about 5 minutes. It's painless. There's no downtime after the procedure. The biggest risk of this laser is, really that it may not work in about a quarter of patients, but it does work about 75% of the time.
Jesus
Equivalence
Christ.
is about to 1 drop. And yeah, in other parts of the world, SLT is the first line of treatment before drops because it is a cost-effective procedure with low risk. Before I move on to other procedures, I'm just going to look in the chat right here just to kind of get some questions, get through some questions here. Okay, so I think there's 2 questions about pseudoexfoliation. I think this could be a good time to talk about pseudoexfoliation. Well, pseudoexfoliation is a type of secondary glaucoma. So there's primary open-angle glaucoma, and then there's secondary open-angle glaucoma. Secondary open-angle glaucoma could be pseudoexfoliation, or it could be pigment dispersion. But these are 2 forms that have either a pigment or pseudoexfoliation material that clogs up the drain. And so that creates a plumbing issue, and it can increase the pressure. And so if this material is clogging up the drain, then that's not very beneficial. That's not very helpful for, the plumbing system, and it can cause the eye pressure to go up. Oh, okay. So this question relates to selective laser trabeculoplasty. How many times can we do it? Well, that's a really good question. You can generally repeat the procedure if it's been effective, but typically we think of repeat SLT procedures as being less effective. But actually, if you get a good response, we're going to repeat it. And as long as we get a good response, we can repeat it. But there will be a point where you don't, where you do not get that response. And it's variable based on the patient as to how many times you can, perform the procedure. Oh, good question. I like your wording. How come SLT is not the first line of defense here with patients in the United States? Do other countries have higher success rates with glaucoma due to using SLT? SLT is often used first, and it's used in early stages of glaucoma. We would not be using SLT and later forms of glaucoma. I think that SLT is catching on, and I think you'll be seeing it used more and more here in the United States, and that's because a few studies that have recently been performed, which are showing that this is a really good option, and it's very cost effective. And so I think if it was my eye, I would actually opt for the SLT laser first, because like I said, the biggest risk is that it may not work, and if it doesn't work, then we're kind of in the same spot that we were before the procedure. And so using drops would be the next step after that. But if we can, if I could avoid eye drops, then I think that's a very good option. But we'll use them if we have to. Yes, I do. Regarding eye health, is it not a good idea to wear eyeliner on the inner eyelid? I think you're referring to like the waterline. I don't think it's a good idea to wear eyeliner on the inner eyelid. That's because, we're not talking about dry eye here, but I will touch on it because you asked. Whenever we're putting eyeliner on the inner eyelid, sometimes you're covering some of the glands that create tears. And if we clog up those glands, then, your tear film will not be very, healthy. And, you might develop some irritation, blurry vision. And so we do want to try to avoid putting eyeliner over the waterline. the inner eyelid. Okay, I might move on. I will come back to some of these questions here. Okay, so what's another way that we can, avoid drops? Well, MIGS or microinvasive glaucoma surgery is a newer area which has really developed in the last decade, and these are procedures in the OR, but they typically require a shorter operation time. It's not considered really an incisional surgery where or a big gun glaucoma surgery, and these are nice because it allows for a little bit more rapid recovery. These are the implants here you can see on the left that we may use to stent open the drain. And over here on the right, these are more to clean out that filter. And you can kind of think of some of these as like almost like doing a roto-rooter for the drain. And so these work by bypassing the trabecular meshwork, really the stents on the left and these that clean out that filter on the right as well. And so, what if this does not work? Well, we do have incisional surgeries, which we can use, which we often use. I'm in the OR tomorrow and I'm doing multiple of these incisional surgeries as along with the MIGS. And, it depends on the patient and what stage they're at, but generally we're going to go and we'll try the minimally invasive or microinvasive procedures first. If they're not, if their pressure is controlled, then we'll move on to the more incisional surgeries. And so this is the trabeculectomy. It's the workhorse for ophthalmology, and this has been around for decades. It's actually, this incisional surgery, you can see, let me see my pointer here. You make this flap, and it's kind of like this trap door. Under this trap door, you make this little opening, and that allows fluid to be released from the eye in a very controlled manner. And this forms a bleb, which you can see here. And, usually this is under the upper lid and you don't see it. And you can see here, it's pretty low profile. And, I want to include this because it is the most effective surgery to control intraocular pressure and stabilize glaucoma and get off eye drops. The next step, another incisional surgery. Lastly, we'll talk about the glaucoma drainage devices. And, you may hear tube or you may hear tube shunt, but this is a wide variety of these. And, they're the plastic plates that you put on the surface of the eye, and this tube goes into the eye and it allows fluid to be released around the plate. And, these are very effective as well. And, typically, you may be concerned about this implant being on the surface of the eye, but really you're not going to be able to tell that the implant's there. You're not going to be able to see it. It sort of becomes a part of the eye, sort of like a hip replacement or an implant, a hip implant. Okay, so what if you're just like, you're interested in glaucoma and maybe you're on a drop or two and you're like, well, what can I do? What can I do to, take control and, maybe have a positive effect on my eye pressure? Well, there are things you can do at home. Multiple studies have shown that dynamic exercise such as walking, jogging, running, cycling, it shows that it reduces your intraocular pressure. And, typically their pressure reduction will be about, for 30 minutes at rest after the procedure, up to 30 minutes. And so this hasn't been looked at. And, I'm not telling you to go and exercise and run marathons or anything like that, but there are studies looking at, patients who engage in, dynamic exercise and the rate of glaucoma. And, it does show that it's beneficial, as it is beneficial for, other parts of your body as well. As far as diet, foods high in dietary nitrates and antioxidants are helpful. And so those foods high in dietary nitrates are green leafy vegetables, root vegetables such as beets, tomatoes. Those provide an exogenous source of nitric oxide and have been shown to lower intraocular pressure as well. There have been a couple of studies looking at meditation, and it does seem to have the effect as be effective as a medication. And you know, it's also just good for your mental health as well, right? Caffeine. So caffeine, I'm not that this is the only one on here that I'm saying, well, maybe we should just hold back on the caffeine. And typically, if you have glaucoma, you know, a cup of coffee is not gonna, you know, um, have a strong effect, but you know, caffeine has been shown to elevate your pressure up at 30 minutes after consumption, and it produces this increased pressure for about 90 minutes following your caffeine intake. And so typically for patients with glaucoma, I just ask that they don't consume excess caffeine, and they use it in moderation. So with that, you know, that wraps up my slides. I hope this has been helpful. I'll jump back into the Q&A here and see if we can take care of any of the unanswered questions. And I'm glad to answer more questions as well. Okay, let's see here. I think we talked about this one.
Dr. Fox, we can invite them to unmute themselves if they'd like to ask the question instead of typing it in the chat.
Oh yeah, that'd be great. Yeah, feel free to unmute yourself and we can talk about it as well.
Hi, Dr. Fox. I have a question. I have low eye pressure, but I have glaucoma. So if the eye drop is to lower the eye pressure, does that benefit me? I'm using eye drops every day.
Good question. Yeah, so that's kind of in that class of glaucomas that I kind of alluded to, but it's normal tension glaucoma. And so, you know, your pressure may have never been above 21 or 22 if you have normal tension glaucoma. We do know that even if your pressure is not above 22, you know, and it's normal tension glaucoma, you do get progression of glaucoma even at normal pressures, right? But we do know that at lower eye pressures, even if it's in the normal range, if we take eye drops or lower the pressure with surgery or laser, we do know that you have less chance of progression. And so your glaucoma specialist is probably set a target pressure based on the pressure that you have shown progression at. And you know, we're keeping you at a lower pressure with the glaucoma eye drops. And so it's really, really important to maintain the glaucoma eye drops, even though you're a normal tension glaucoma patient.
Thank you.
Yeah, absolutely. There was a question about lifestyle. We talked about lifestyle. The other thing that this question alluded to was genetics. Genetics is incredibly important. And we're learning more and more about the genetics of glaucoma. And, you know, it kind of goes along with the family history. The family history is a very strong risk factor. Typically, family history seems to be very strong for patients with severe glaucoma. If you have a family history of mild glaucoma, it may not correlate as strongly, but it's still very important because if family history is just a very strong risk factor. Okay, let's see.
Dr. Fox, I have a quick question. Can you hear me?
Go ahead, I can.
Okay, so my dad has high blood pressure and he's got, I would rate it severe glaucoma. And he's on Zioptin and Cosop, and I believe it's the Zioptin that is preservative-free, correct? Or both of them are. But one of them, I believe it's the Zioptin, can increase your blood pressure. Is there another medication that's preservative-free that might be a better medication for him to use to keep his blood pressure low?
Yeah, that's a good question. You know, these prostaglandin analogs, if you read on the packet, the insert, it's, you know, the rate of high blood pressure with these is pretty low. It's about, you know, I've seen about 5% in the inserts I've read, but it can really increase your blood pressure. And so, you know, I think that it's hard to say whether you're going to see that effect with a different prostaglandin analog, but it might be worth getting out of that class if,
Okay.
you know, there is an issue with managing the blood pressure. Maybe
it.
trying a Rho kinase inhibitor like Ropressa or Natarsadil. You know, it's hard. I don't like to discount full classes if we can help it. And so one option in that case, I'm not sure of the other options other than the Zioptin that he's tried, but you know, maybe a good option might be to try like a Zelpros, which is a preservative-free version of latanoprost. And you know, if you experience the high blood pressure with the Zelpros, then we might have to discount that class of medications and go to a different class.
Okay, got it.
Yeah,
Thank you.
absolutely. I don't mean to you know, neglect the question about pharmacy benefit managers. You know, insurance is incredibly complicated. A lot of times they do require step therapy. And you know, I'm thinking about cost whenever I'm prescribing these medications because they can be expensive. As you can see right here on this screen even, you know, I go to GoodRx and I can kind of estimate the cost of the drop. This does not include like insurance coverage. You know, other ways to kind of get around costs would be this GoodRx coupons essentially can, you know, decrease the cost. Eagle Pharmacy is a good way that you can get Zioptin actually, and preservative-free Cosopt, and it's a pretty reasonable price. And then the Ropressa saving card is pretty helpful to decrease the cost of Ropressa because Ropressa can be actually a little expensive as well. This is the Eagle Pharmacy insert right here. And so your ophthalmologist would send the prescription to Eagle Pharmacy. It's in, I believe it's Lakeland, Florida, and they would send it to you. So glaucoma patients, okay. I'm not sure I get the question about glaucoma patients and PIs. PI, you know, we didn't talk about narrow angle glaucoma. That's a different type of glaucoma. It's where the drain is actually very narrow. So if you think of a sink drain being very narrow, there's going to be a buildup of pressure upstream. And so a PI is a peripheral iridotomy, and we often use that. It's a laser procedure. It's used to open up the drain.
Dr. Fox, I'm the patient who has macular degeneration as well as glaucoma, and
yeah.
I am probably going to have cataract surgery, apparently. I'm getting really, I'm really freaking out over this, as you can imagine. The drops are working for me, but it took several months before they prescribed drops that actually brought my pressure down. I'm very nervous about having cataract surgery given the different problems I'm having because my vision is deteriorating. Within a year, I've gone from, you know, 20/30 to 2400 in one eye and 20/80 in the other eye. So I'm really having, you know, I'm really restricted. So I'm very nervous about the thought of having to have cataract surgery. What is your thought on that?
That's a good question. So I can imagine that it's very, you know, there's a lot of anxiety with any surgery. You know, I've had surgery myself, and you know, then we're talking about the eyes. So, you know, I think that I hear what you're saying, and you know, it's hard to completely understand your case because I haven't seen you in clinic. But you know, cataract surgery is a great surgery. You know, there's about 5 million cases in the United States every year. It's gotten safer and safer. And so I just want to reassure you about that. But with any surgery, there's risk, right? And so we do everything we can to mitigate these risks. You know, make sure there's no infection, clean around the eye, make sure your eye is very comfortable. You know, make sure that your macular degeneration is taken care of. And make sure that we kind of decrease any swelling in the back of the eye with your retina specialist. And then, considering other ways to control the pressure depending on the stage of the glaucoma in combination with the cataract surgery. It's hard for me to comment like on the specifics, but, I just want to reassure you that, cataract surgery is very, very safe. And I think even though it's very safe, you definitely, the concern is warranted. And so, we don't like messing around with the eyes, and, if we can avoid surgery, we can, but, unfortunately everybody gets cataract. And so, ultimately individuals have cataract surgery, and, it's, I think that you're in a good spot as long as the pressure is controlled with drops. But it might be worth considering another procedure to try to get off the drops as well and control the pressure.
Okay, thank you.
Yeah. Oh yeah. So if you don't have glaucoma and your pressure is low, you don't necessarily need glaucoma eye drops. That was another question. There's a question about types of glasses or lenses to help combat the tunnel vision produced by glaucoma. There are low vision devices that we can use to help individuals, live and do their activities of daily living. There's not a device or a glasses that's going to expand the visual field that we've already lost. And so that's why it's just really important to, screen for glaucoma and try to catch it early, and, try to work with, your provider or work with patients to try to make the drops as tolerable as possible, and, find the regimen that works for each patient. Okay, I'm just moving on. Oh, good question. What clogs up the trabecular meshwork? It could be really, really anything that is floating inside the eye, like the pigment dispersion, that essentially the iris, the colored part of the eye, has pigment on it, and it can, slough off and clog up the trabecular meshwork. Pseudoexfoliation type of glaucoma, the pseudoexfoliation material can clog up the trabecular meshwork.
Can you call her?
And then, a lot of times we see patients who have had inflammation in the eye. The inflammatory material can clog up the trabecular meshwork. If you have diabetes and you have vessels that are, growing inside the eye because your diabetes is not well controlled, that can clog up the trabecular meshwork. So I've given a lot of examples, but it's really like anything that's going to clog up the pipes can increase the pressure and cause glaucoma. That's a good question though, because there's a lot of possibilities. I'm glad to share my slides. Dana, I don't know if that's okay. I'm glad to share them.
Yes, we'll share the full presentation once it's edited down.
Okay. Yeah, there's a couple of good questions. I think there's there's a question about regeneration of the optic nerve, or regrowing the optic nerve. There's a lot of work being done. There's nothing that's in clinical trials right now, but this is more work being done in the laboratory. There's a lot of promising work being done, and it's something that I'm really excited about. I think that there's a lot of funding that's been directed towards regenerating the optic nerve, but there are a lot of connections from that optic nerve to the brain. The vision center in the brain is in the back, and so it is incredibly complex, and I think that it's going to be a while before we see this research being applied clinically in clinic. Yeah, there's so it's asked about benzalkonium chloride. That's the main preservative that we use to preserve eye drops. Here's a list of different options for BAK-free or preservative-free drops. you know, they're always trying to come out with new medications to try to preserve the eye drops so that we make them more tolerable for patients. And, you know, ultimately, you know, moving towards these implants and these sustained release, extended release drugs, that's going to be the, you know, it's only going to get better and better. This is going to be the best thing to try to move away from the BAK. Oh yeah, good question. The nano adapters are available. They're available through the website. You know, I don't know if they're yet available in our optical shop, but you can get them through the website, nanodropper.com. And you know, essentially it's a logo like this. You can buy them at a pack of 3, or you can just buy one individual just to see if you like it. Yeah, you can, they are available online. Any other questions? I think a lot of good questions. I appreciate all the questions. I appreciate y'all's attention and sticking around and, you know, allowing me to talk to you about glaucoma.
All right, well, everybody, if there are no more questions, we'd like to thank you for joining us tonight. It looks like we're ending right on time, which is just amazing. Dr. Fox, thank you for another great presentation. And as we said at the beginning, this lecture was recorded. Once it's edited, it'll be posted on our website, and we will also send it to everybody who registered. So please be on the lookout. If you'd like to reach us for anything, you can email us at ophthalmology.uci.edu, and one of us will get back to you. We look forward to seeing you in September at the next lecture on general ophthalmology. Thank you very much for coming, and have a good evening.
Thank you, guys. Take care.